Hi, everybody. Dr. Peter Nord here. I'm the Chief Medical Officer at Medcan. I'm excited today to welcome Dr. Beth Abramson, and she is our Clinical Director for Cardiology and has been for about 10 years, leading the charge on all things cardiovascular. Welcome, Beth.
It's a pleasure to be here. It's exciting to be part of Medcan as we innovate and we prevent disease. And I have more than one hat. I actually am at the University of Toronto. I have a chair in cardiology now with a focus on preventive cardiology and women's health. And so it is just wonderful to be able to move the needle when it comes to reducing risk and keeping me less busy when I'm on call for cardiology.
Terrific. And a published author as well.
Wrote a book geared a few years ago, but still relevant, geared at making sure people know what questions to ask, because you don't have to know the answers. You've got great healthcare providers and doctors and allied health providers who can help you with the answers, but navigating our environment and knowing which questions to ask is really important. We see cardiovascular disease across the spectrum in our population, and the numbers are actually concerning, but by the time you're at midlife, you're 50 or so, you have almost a 50% chance of developing cardiovascular disease. 1 in 5 individuals, even when they're younger, will have risk factors. And a lot of heart disease is preventable. Sometimes we talk about heart healthy behavior and changing lifestyle, and it's obviously harder to make a lifestyle change sometimes than take a pill. But we want to screen everyone and all our clients and the population for risk for heart disease. High blood pressure, high cholesterol, a tendency to diabetes, helping people maintain a healthy body weight, get active, not smoke. All those aspects are important at preventing heart disease. Medcan orders something that much of the world doesn't order, called a sensitive troponin, which is a marker for future risk and helps us sort out who's at higher risk. Yeah. I know we also offer individuals who come through the doors the bare minimum that all of our guidelines are now saying once in a lifetime we need to check this Lp(a) molecule. It's a cholesterol molecule. We can talk about it. And the rest of the world's behind the 8 ball here, and Medcan's leading the way. So I'm very happy about that. And we have other tests that are specific to cardiovascular risk that are offered here at Medcan.
So on the topic of Lp(a) and ApoB, kind of exciting because we are now incorporating both of those biomarkers, those very important biomarkers, in line with Canadian guideline recommendations into the core basic panel that everybody's going to get in the annual health assessment.
I think that's great. Medcan is leading the way. Lp(a) is a protein that carries cholesterol. It is 95% genetic. So I make a joke that you could be 400 pounds and going to McDonald's every day and not active and have a normal Lp(a), or be, the picture of fitness. In fact, if you're a tennis fan out there, Arthur Ashe was a very fit athlete who died of a heart attack very young age. And he had an elevated Lp(a). So if we don't look, we don't find it. And it's a protein that carries cholesterol. It causes blockages, it causes inflammation in the artery, it can cause sort of rust in our pipes, and it causes clotting. So it's something we need to be aware of. The numbers suggest about 1 in 5 people have an abnormal Lp(a). Mm-hmm. So I'm glad we're starting to check for it.
Yeah, I'll tell you, I checked mine 2 years ago, and cholesterol was great. The ApoB is fine. The Lp(a) should be less than 50. Mine's 250. So I'm one of those people that suddenly, if I hadn't checked my Lp(a), I wouldn't have known that I'm actually at higher risk, which then you sort of say, okay, so, but you're already like good on cholesterol, means I have to even better.
Right. So it's not, by the way, it is not, and not for you, for anyone, it is not a death sentence. It's a marker for long-term risk. And we can manage that risk. We have evolving evidence and guidelines. And, at my university role and world, we're doing a national registry in people living with Lp(a). So there's a lot of evolving science around Lp(a). And right now, we eliminate cholesterol from the body if you have a high Lp(a). So it's diet, lifestyle, and in some patients, medications.
Yeah. So maybe we can talk a little bit about ApoB because we brought that up. So maybe a little bit double click in terms of the ApoB and what that's about.
Yeah. ApoB is also a cholesterol molecule. I want people to remember B is a bad guy. And B is what we call atherogenic. It can cause junk or rust in our pipes. And it's the main cholesterol molecule that causes this problem. We often, over the years, and we still do measure the LDL or lousy cholesterol, but that LDL can be influenced by other blood fats in our body, and how we check it, whether it's fasting or not, changes the number. But the ApoB, LDL is mainly ApoB. ApoB is the marker that is the most direct measurement, and it can happen whether you're eating or fasting. You can have it checked, and it tells you another aspect of your risk for cardiovascular disease. I mean, if we don't look for it, if we don't see it, we don't know. And a lot of cardiovascular disease, risk for heart attack and stroke in the long run, is preventable, but it's picking up that risk and lowering that risk in various ways. So knowing what your risk is, picking it up early, and lowering that risk over a lifetime is beneficial for everyone.
For sure. And so much of it is asymptomatic as well. So much of what we see are people that have no symptoms.
Absolutely.
They're coming in, maybe they were incentivized by a loved one to come in, or their employer suggested they can come in. And so they say, yeah, my wife said I should come in. And all of a sudden we find stuff. And there's almost nobody who comes through that we don't find something. Hopefully good stuff as well, but maybe some red flags that we can start to deal with, because they were, you don't feel high blood pressure.
Can't feel a risk for heart disease. Unfortunately, it's called the silent killer for a reason. So there are some good opportunities that we have with the evolution of science and these biomarkers and blood tests. We also can look at the heart muscle function. We can look at an ultrasound of the heart and an echo test. And we're in an era where we tend to order a test when people are having symptoms, but in the prevention world, I do agree that it is good to order tests in people before they have symptoms, depending on that individual and other risk factors. And having been here almost a decade at Medcan now, we've picked up and we've had some real saves because of the screening of somebody who normally wouldn't be screened. And that's just makes one feel good about making a difference. And I think prevention is the way we all have to go from a larger societal perspective.
Yeah, for sure. And I think it also fits nicely into the whole strategy that we have at Medcan. We have this concept of the 5 pillars of wellness. And so brain health. Well, if we look after our arteries, not just the heart artery, the brain arteries are going to be well looked after as well. Obviously, atherosclerotic heart disease, but also the other vessels, kidney disease. If we have bad arteries, it could affect our limbs. We could end up with an amputation. Cancer, we've already talked about. And then metabolic issues. We want to make sure that from diabetes and other metabolic conditions, we're picking up on that early, managing that early. And then mobility. If we're not mobile, we don't have quality of life. So the whole focus on heart health and atherosclerosis is central to this sort of the 5 pillars of healthy living.
And it goes together with preventing chronic disease, because actually risk factors and prevention of heart disease and actually cancer can be similar. We want to try and maintain healthy body weights, eat less saturated fat in our diets, be more active. There's a lot of good evidence that the disease pathways for chronic disease are similar. And sometimes it's hard to do, and you need a little extra help and support. And as we age, and as women age and go through midlife or menopause, their shape changes from the pear-shaped weight gain to the apple-shaped weight gain. And that apple-shaped android weight gain is metabolically active fat that puts us at risk for cardiovascular disease.
So in that same vein, we're going to put up a graphic.
Artery, not vein. That's a joke.
Yeah, good. I love it. And I really like this graphic because in one touch of the eye, you sort of see a lot of what's going on from the... I like it because I often will talk to my clients about the biology of the artery. What is happening? And we've learned so much over the last 15 years about what's really happening. The arteries are metabolically very active, and we're learning hand over fist these days what's actually happening at the micro level. And the graphic really gets to that. And it starts to show how progression from a healthy artery to an artery that's essentially blocked, causing a stroke or a heart attack, causing kidney issues. So that's all in sort of one picture.
Yeah, and I think it's really important to think about that concept of as a disease of the arteries, because it's not your heart that has the problem, it's the blood flow to the heart. So heart disease and that artery is really a pipe. I look at it this way. It's a disease of the arteries, whether it's to your right, to your neck arteries, to your brain, the heart arteries can cause heart attack, or the leg arteries, it can cause peripheral vascular disease or arterial disease, which is a very serious condition as well. And what we want to do is keep those arteries healthy. So buildup of junk or atherosclerosis in the arteries is a process that occurs over decades, from high blood pressure, diabetes, smoking. And if we can track and make sure that those arteries are, if they're diseased, make them healthier earlier on, we can prevent a clogging of those arteries and a buildup of bad events. So treating that artery, if we pick up a diseased artery, and actually Medcan offers a test called carotid IMT, which I do want to remind people, it's a sign of the artery health. If the arteries get thick before they become unhealthy, before we start seeing junk in the arteries. There are other tests down the road that people look at to see if there's been inflammation and the arteries have been unhealthy. We build up calcium, or coronary artery calcium is built up when there's inflammation healing. And then we ultimately get junk in our arteries that put us at risk for heart attack and stroke. And we want to catch that early and treat that diseased artery.
And maybe you can talk a little bit about the pathophysiology and a little bit about how that Medcan is able to offer some tests to actually get at the pathophysiology that's going on there.
So we can look at the artery, and there are some appropriate ways to look at the artery. And the way that Medcan does a carotid intimal medial thickness assessment, which is called CIMT, is through sophisticated computer edge detection software. And so a thickening of the artery is the first sign of an unhealthy artery. And then you can see as the artery becomes more unwell with junk buildup, you can see plaque buildup, and we want to prevent that as well. And we can check the biomarkers, the blood tests, the cholesterol markers that are raised that cause arterial abnormalities. And when the artery is damaged enough, we will have symptoms. And symptoms of a narrowed, blocked artery, if we're lucky and have symptoms and don't have a sudden death, occur only when that artery is over 70% narrowed. So the whole idea is to pick this up before a patient has symptoms and reduce someone's risk. We don't have to go down into our coronary arteries to see that the health of a blood vessel anywhere in the body is reflective of a blood vessel elsewhere. And that's why we sometimes can look at the neck vessels. And making sure we reduce our risk through various strategies, looking at our biomarkers, reducing cholesterol, looking to see if we're at increased risk with a troponin test that we do in the office setting here, are all ways of detecting early blood vessel disease.
Yeah, it's actually one of the things that when we brought HS troponin in, it was really because we were doing exercise stress testing as a screening test. And we realized that that's only going to be positive when you're 70% blocked. So, you know what? The horses left the barn on that one. And then we're into damage control basically at that point. Whereas HS troponin, we're looking way earlier in the process and trying to pick up those red flags early. Yeah. So we're not doing exercise stress testing anymore. And that's when HS troponin happened to come on the scene. We were the first in Canada to really mobilize with that. And now we've probably done, 50,000 of those tests at this point,
and
something?
You know, Peter, I'm actually proud to be a Medcanner for this because this was the right decision to make, because we don't do routine cardiac stress testing in people who don't have symptoms. You need that 70% narrowing in the diagram. We can do it for fitness. It's great to know a fitness test. That's different. But this troponin, which is a blood test that we're using in the office setting, which is different setting than if you're coming in with chest pain to the emergency room. The same test, but the test is elevated much, much higher if you're having a heart attack in the emergency room with chest pain. And the very microscopic level, we can pick up that the heart muscle cell isn't in a healthy environment. And we've published on this. We've been published in the Cardiology journal because we're at the forefront at Medcan, and spoken internationally that we have a test that helps people sort out, are they at slightly higher risk for heart disease? And there's good data to that. You know what this troponin has picked up is very interesting. We have the ability to order ultrasounds of our heart and an echo test where we can look at the heart muscle function and the valves. And we've picked up some people who also would have had silent problems with valve problems, and their aorta, the main tube to the heart's been big. So it's been a very useful test for people walking through the door. Once we help them understand, what this is about. This is not having a heart attack. We're using it in a very different and I think very forward-thinking way.
I think at the end of the day, it's what I hear on the front lines all the time. And we hear it from our different parts of the business. Medcan saved my life. And we can't tell you how many times that, or Medcan saved my wife's life, or Medcan saved my buddy's life. And that's happening all the time, like every single day. Last year we did 25,000 annual health assessments. Out of that 25,000, there's a whole number of people that were acutely saved and then chronically, set things in motion that add years to their life and healthy years to their life. So very exciting times and looking forward to more innovations to come.
Absolutely.
Once again, thank you everybody for joining us. Thank you to Dr. Beth Abramson. Fantastic, exciting discussions. Lots more coming your way as we innovate in the area of cardiovascular as well as the other areas that we're really focused on. So once again, thank you for your time. Thanks everybody and stay well.
This podcast episode is intended to provide general information about health and wellness only and is not designed or intended to constitute or be used as a substitute for medical advice, treatment, or diagnosis. You should always talk to your Medcan healthcare provider for individual medical advice, diagnosis, and treatment, including your specific health and wellness needs. This podcast is based on the information available at the time of preparation and is only accurate and current as of that date. Source information and recommendations are subject to change based on scientific evidence as it evolves over time. Medcan is not responsible for future changes or updates to the information and recommendations and assumes no obligation to update based on future developments. Reference to or mention of specific treatments or therapies does not constitute or imply a recommendation for endorsement. The links provided within the associated document are to assist the reader with any specific information highlighted. Any third-party links are not endorsed by Medcan.